So it is time to start. Actually, the time duration for this lecture is 2 hours. It may not be 2 hours, maybe less than that, but definitely it is more than 1 hour. So we, on the safe side, allotted 2 hours for this lecture because there are several drugs in this class. So today we are going to discuss drugs used in peptic ulcer. The objective of this lecture is not to going into the pathophysiology of peptic ulcer, because I'm sure there's someone else, pathologist or clinician, has already discussed the pathophysiology, but definitely we'll touch upon a lot on physiology because the drug targets depend on the physiological background. So we'll talk a lot about physiology, especially of the hydrochloric acid secretion. Specifically, as the first learning objective, about 1/3 of the lecture is revisiting the regulation of gastric acid and mucus secretion. Because without having a solid background knowledge of this learning objective, you won't understand the mechanism of action of several drug classes in this lecture. And then, after understanding the mechanism of HCl secretion, then we will classify the drugs used in the treatment of peptic ulcer. And then we'll correlate the mechanism of action of each class of drugs with their use in the management of peptic ulcer. And then, of course, as usual, some important pharmacological aspects, especially the adverse effects and some pertinent drug interactions, if there are any, we'll discuss while discussing those drug classes. Okay. Now, not the whole pathophysiology of ulcer, but primarily you should appreciate that there is some imbalance between the defense mechanisms and aggressive factors in the stomach and intestine, which will lead to causation of development of peptic ulcer. Okay, on the left side, you can see several aggressive factors, and most important among them is acid, especially the hydrochloric acid secreted by the parietal cells of the stomach, and then the bacterium H. pylori, Helicobacter pylori. These are the aggressive factors which are having a pivotal role in the development of peptic ulcers. In majority of these H. pylori, not all. And there are several defensive factors which prevent the development of peptic ulcer, or actually they hinder the development of peptic ulcer. For example, mucus protective layer in the stomach and intestine, and bicarbonate secretion, and prostaglandins. Now, based on these mechanisms, aggressive as well as defensive, the whole pharmacotherapy of peptic ulcer depends upon two things, two strategies. Either you blunt or decrease the aggressive factors by decreasing the acid or killing the bacteria, or at the same time, and or you enhance the defensive factors, increase the mucus production, increase the bicarbonate production, or increase the action of prostaglandins. We'll discuss one by one. So this is a basic philosophy. Either blunt the aggressive factor or enhance the defensive factor, or both in the management of peptic ulcer. Is that clear up to now?
Yes.
Yes.
Good. Now, based on this basic understanding, now the strategies, pharmacotherapeutic strategies in the management of peptic ulcer can be divided into 4 strategies. Namely, simply neutralize the acid in the gastric lumen, or decrease the acid output from the parietal cells, decrease the secretion of acid, or enhance the mucosal resistance of the gastric and intestinal walls towards HCl, as we mentioned. And finally, eradicate the Helicobacter pylori with antimicrobial drugs if the microorganism is the cause of the ulcer. Before initiating treatment, you have to determine whether in this particular patient H. pylori is associated with ulcer or not. If H. pylori has not been detected, there is no need of using antibiotics in that case. There can be several other causes of peptic ulcer, for example, NSAIDs and other things, Bollinger-Ellison syndrome. In that situation, there is no need of using antibiotics. That is why I have put this learning strategy as conditional. Eradicate the H. pylori with antimicrobial drugs if the microorganism is the cause of ulcer. If not, there is no need. Now we will discuss all these 4 strategies one by one. First of all, neutralize the acid in the gastric lumen. Okay, let me ask you one basic chemistry question. How do you neutralize acid?
By bicarbonate.
By bicarbonate or
By a
amine?
base.
Okay.
By a base or an alkaline.
The alkaline. Okay, good, very good. So antacids. Antacids are a group of drugs which increase the pH of the stomach by neutralizing the acid. They are antacids. There are 2 types of antacids, systemic. For example, one in this glass, sodium bicarbonate. Systemic means the one which is absorbed into the systemic circulation and has systemic effects. And there are non-systemic, that means they act locally in the GIT. They are not absorbed into systemic circulation, and their action is localized in the GIT. Aluminum salt, aluminum bases, aluminum hydroxide, magnesium, and the combination megaltrate. We'll discuss all these one by one. All these antacids are basically weak bases that neutralize acid. Now, this is an important lecture in the science. Do you remember I delivered a lecture in PUD, the mechanism of action of drugs? If you recall, let me refresh your memory, that when we were talking about how the drugs act, majority of the drugs, about I think 96, 97% of the drugs, they act through receptors. There are few drugs in clinical uses which do not require receptors for their action. They can act chemically, they can act physically. The presence of the drug is producing some action, and the chemical reaction brought about by a drug confers the drug a pharmacological activity. So in this lecture, interestingly, there are at least 2 drug classes which act through mechanisms not dependent on the receptors, and antacids are one of them. They do not require any receptor. Simply, a chemical reaction brought about by these drugs confers the drug a pharmacological, a therapeutic activity. There is neutralized acid. They also inhibit the formation of pepsin, and pepsin, because pepsinogen, zymogen is converted into pepsin acidic pH. Once you increase the pH of the medium, the pepsinogen is not converted into pepsin. Now, although I am restricting myself not to discuss detailed pathophysiology, but just let me ask you, do you know the role of pepsin in the development of peptic ulcer? Anybody? What is the role of pepsin in the development of peptic ulcer? It actually worsens because pepsin hydrolyzes proteins. Once the surface of the epithelium is exposed, it is eaten by the pepsin and ulcer is worsened by the pepsin. Sodium bicarbonate, a systemic antacid, potent acid neutralizing capacity, and acts instantly, right away. Right away, if you have heartburn or some hyperacidity symptom, you take sodium bicarbonate within a minute, the acid will be neutralized. But there are some demerits. It's very quick, but demerits are, since it is systemic, it enters into the systemic circulation, it may cause systemic alkalosis. It interferes the pH of the body fluids, especially the blood. And it may cause distension, discomfort, and belching due to excessive carbon dioxide production. Rebound acidity, once the effect of it is gone, the acidity may come back with more force. And in some patients, it may be contraindicated because, as I mentioned, it is systemic. It may cause sodium overload in the body, which may actually worsen the conditions like edema and congestive heart failure, in which conditions sodium intake is restricted. And by virtue of administration of this drug, sodium load will be increased, which may worsen these conditions. So that is why use of sodium bicarbonate is restricted to casual treatment of heartburn since it provides quick symptomatic relief, not for the long run. Other uses of sodium bicarbonate are to alkalinize the urine and treat acidosis. Is there anybody in the meeting room to tell me why would you like to alkalinize the urine in some situations? Anybody? Okay.
Prevent formation of some.
Yes. Okay. Because in the toxicology, you will see there are various acidic drugs. When they are accumulated, they produce toxicity. Once the drugs are in the systemic circulation and you do not have a specific antidote to that drug, one major mechanism of accelerating the excretion of those drugs, acidic drugs, are to make the urine alkaline so that while passing through the kidneys, the drug may precipitate and the acceleration, the excretion of the drug is enhanced. In some toxic situations like aspirin and other things, you alkalinize the urine and the drug is drug excretion is accelerated in alkaline medium. So that is one mechanism. And then there are several metabolic acidosis conditions where you can use sodium bicarbonate systemically, not as antacid orally, but as an injection. And then some discussion on non-systemic antacids. They are insoluble and poorly absorbed basic compounds. So if they are not absorbed, they act locally and their effects are localized in the GIT. They react in the stomach to form corresponding chloride salts. Chloride comes from HCl and divide of systemic adverse effects. So they are better, they are preferred. Now, chemical reactions, as I mentioned, they do not require any receptor, just the presence of these drugs produces a chemical reaction, which is a pharmacological activity. We discussed about sodium bicarbonate. It reacts with HCl and produces salt, sodium chloride, water, and carbon dioxide. Likewise, aluminum hydroxide, another widely used antacid. It produces aluminum chloride and water after reacting with HCl. And the third one, which is also very commonly used, magnesium base, reacts with HCl and produces magnesium chloride and water. So these are the chemical reactions. And adverse effects, aluminum antacids, they produce constipation as they relax gastric smooth muscle and delay gastric emptying. Otherwise, they are safe. Only one local side effect. Another local side effect of magnesium antacids is osmotic diarrhea. So they have opposite side effect. Aluminum and magnesium, they produce constipation and diarrhea respectively. So in renal failure, aluminum antacids may cause aluminum toxicity in spite of the fact that they are minimally absorbed. But even that slight increase in aluminum in the context of renal failure may produce aluminum toxicity because then it will be accumulated. So you have this in renal failure, aluminum-based antacids are contraindicated.
Doctor?
Yes, please.
You said that they act locally, like in the gut. How will they move to the blood?
So in the previous I mentioned the slide, you can see poorly absorbed basic acids. Poorly means almost nil in the normal situations, but a slight increase because to some extent they are in maybe 1 to 2% of the orally administered, but that 1 to 2% becomes clinically significant in the context of renal failure. That is my point here.
Okay.
Okay. I think this bullet we had already covered in PUD block when we were discussing about the tetracycline drugs. Tetracycline drugs should not be given. In that context, we had mentioned the and I remember in your class or after your class, there was a question in the PUD final examination, the drug interaction between tetracyclines and antacids we had asked. So this is once again emphasized that all these antacids, they adsorb drugs and form insoluble complexes that are not absorbed. They are themselves are not absorbed, and they complex with some drugs. And among all the available drugs, tetracyclines are most notorious of being absorbed by these antacids. And since antacids are not absorbed, those drugs are also not absorbed. So there should be a duration of 4 to 5 hours between administration of these antacids and tetracyclines in order to not to inhibit the absorption of tetracyclines from the GIT. So these are the drug interactions of antacids. Now let me ask you a question. Is it rational to combine aluminum hydroxide and magnesium hydroxide in antacid preparation? Can you combine two antacids together?
Maybe yes, just produce the side effects of
Yes,
the.
very good. And the fact is that when you go to the pharmacy and purchase any of the over-the-counter antacid preparation, you will find a combination of both aluminum and magnesium together in the same. The reason is the same, as you mentioned rightly, that the combination preserves normal bowel function. Aluminum hydroxide causes constipation and magnesium causes diarrhea. In order to antagonize these side effects, generally, most of the commercially available antacid preparations are a combination of both aluminum and magnesium. And that gives me an opportunity to discuss one of the commonly used antacid combination, megaldrate. Megaldrate is a hydroxy magnesium aluminate complex that is converted rapidly by gastric acid into magnesium and aluminum hydroxide. These are absorbed poorly, as I mentioned, very poorly, insignificant, but that insignificant absorption becomes significant in the context of some diseases like renal failure, and thus provide a sustained antacid effect. We discussed now antacids briefly. Now, coming back to the strategies, do you remember 4 strategies? Neutralize the acid in the gastric lumen we discussed. Now, the second one is decrease the acid output from the parietal cells. Now, before going into the drugs, a brief physiology, which is brief, but it is very, very important for you to understand. I'm sure many of you might remember GI lectures from physiology. Gastric juice secretion is accurately synchronized with the need for it. When it is needed, it is secreted. When it is not needed, it is not secreted. I mean, there is a basal secretion all the time, but not stimulated secretion. Secretion persists since food is about, there is no need of comma. Sorry. It changes the meaning. There is no need of comma here. Secretion persists since food is about to enter the stomach and continues till food is present in the stomach. So the first phase is cephalic phase of GI secretions, gastric secretions, and the other one is due to presence of food. So the first phase you have to appreciate, you think of the food, or you are on the dining table, or you are in the restaurants waiting for the food. Then and there thinking of the food, smell of the food, appetite is sufficient to increase the activity of the parietal cells or other cells in the GIT. And that activity continues because of the presence of the food. When you actually start eating, the secretion is stimulated, which has started from cephalic phase, just thinking about the food, and continues because of the presence of the food, as long as the food is present in the stomach. Now, based on those cephalic phase and because of the presence of the food in the stomach, you need to appreciate the roles of three important ligands: acetylcholine, gastrin, and histamine in gastric secretion. Now, this is a graphic, the diagrammatic representation of few cells. First, appreciate on the left side, this is a typical parietal cell, the role of which is mainly to secrete hydrochloric acid into the canaliculi, and which ultimately reach the lumen of the stomach and will decrease the pH. And the final common pathway is the activation of proton potassium pump, or known as proton pump, and there will be increased secretion of proton, which will ultimately lead to increased synthesis of in the HCl in the lumen. So this is the final common pathway, but what are the stimuli, what are the converging pathway on these parietal cells which lead to activation of proton pump and hence the secretion of HCl into the lumen? Now this is the pathway. Let's appreciate, we have to start from here. Can anybody tell me what is ENS? What is ENS?
Enteric nervous system.
Very good, enteric nervous system. And what is the nature of this? This is autonomic or somatic?
Autonomic.
And what branch of autonomic? Parasympathetic, sympathetic?
Parasympathetic.
Parasympathetic. And what is the specific nerve which supplies the enteric nervous system?
Vagus.
Vagus nerve.
Vagus nerve. Okay, good. So vagus nerve supplies the enteric nervous system, and since it is parasympathetic here, it secretes acetylcholine. Let's start from here. Once acetylcholine is released, acetylcholine has multiple functions. We'll discuss only two in this context. First of all, one pathway is direct. It directly activates the muscarinic receptors present on the surface of the parietal cells. They haven't been, they have been cloned. They are M3 receptors. And you know, based on your prior knowledge, that M3 receptors are coupled with the G protein and eventually leads to a cascade of generation of 2-second messengers, DAG and IP3, and several protein kinases are activated, eventually which it culminates into the activation of proton pump. So this is one pathway how parasympathetic nervous supply, venous acetylcholine, activating through M3 receptors on the parietal cells leads to increased secretion of acid. But not directly, acetylcholine may also act indirectly through another cell. This is ECL cell. What is ECL cell? What is ECL?
Interior chromophene-like cell.
Very good. Basically, this is a histaminocyte. It causes the secretion of histamine. So this ECL cell is also having input from acetylcholine. So acetylcholine acts on muscarinic receptors and causes the increased release of histamine from the ECL cells. And that histamine in turn acts in a paracurrent fashion and works on it has H2 receptors on the surface of the parietal cells, and H2 receptors activation will also lead to the same like acetylcholine, increased activation of proton pump and increased secretion of HCl into the lumen. So acetylcholine working directly also works indirectly through ECL cells. Let's start. And of course, there's the role of gastrin. Although gastrin has very, very important role in the regulation of HCl, but it is not pharmacological, it is physiologically very, very important, but pharmacologically not important because we do not have any drug which can modify the action of gastrin. So although, let me emphasize that gastrin is physiologically very important, but pharmacologically there is no significance because we do not have any drug to antagonize the effects of gastrin. So gastrin can directly activate the ACL cell. Also, it has direct receptors on the parietal cells. So it has both mechanisms through activation of, increased release of histamine, and directly it can also enhance the secretion of HCl from the parietal cells. Everything clear from this?
Yes.
Yes,
Thank you.
doctor.
Okay, now you can appreciate the targets from here. Since we are now discussing the second strategy, decreasing the acid output from the parietal cells, you need to appreciate where the drugs can possibly act. First of all, muscarinic receptors, okay, histamine receptors, and the final common pathway, which is the proton pump. These can be targeted by decreasing, in order to decrease the secretion of acid from the parietal cells. I already mentioned the role of proton pump briefly. Keloid and proton are secreted actively from the cytoplasm of parietal cells into the lumen of the canaliculus, where they combine into HCl and then secreted into the lumen of the stomach. Proton leaves the cell facilitated by proton pump, as I mentioned already. So this is the same thing. Okay. Now, the second strategy, based on this background, decrease the acid output from the parietal cells. We have H2 receptor antagonist. We already discussed H1 receptor antagonist in PUD block anti-allergic drugs, but here it is H2 receptor antagonist, anti-muscarinic drugs, and proton pump inhibitors. Once again, we are forgetting here the role of gastrin, but unfortunately, pharmacologically, it is not important because we do not have a drug which can modify the action of gastrin. So, some discussion about H2 receptor antagonist. Cimetidine, prototype, but not used now. There are several, but we are focusing three drugs, ranitidine and famotidine. Any drug which ends with tidine is H2 receptor antagonist. H2 receptor antagonists, they are reversible and competitive inhibitors of H2 receptors of histamine. H2 receptors. Highly selective, they have very negligible action on the H1 receptor, so practically you can call them selective H2 receptor antagonists. Highly effective and were widely used, but now surpassed by more efficacious PPIs, proton pump inhibitors. Let me ask you a question. Over the very weeks, the efficacy of, okay, let's forget, very complicated question. H2 receptor antagonist comparative analysis, three drugs, cimetidine, ranitidine, and famotidine. Bioavailability, cimetidine is more compared to ranitidine and famotidine. Half-life, more or less 1.5 to 4 hours of all three drugs. Duration of action is 6 to 12 hours based on the half-life. But this one is important. You have to appreciate inhibition of cytochrome P450 enzymes. Only cimetidine is the one which has very significant effect on the phase 2 drug metabolizing enzymes in the liver, CYP450. So if we just keep the unit of inhibition of cimetidine as 1 compared to cimetidine, because this is the gold standard, ranitidine has minimal and famotidine has no any effect on the drug metabolizing enzymes. Now, based on this activity, can you figure out what will be the outcome, clinical outcome, when a drug inhibits cytochrome P450 enzymes, what will be the clinical outcome?
Increase the enzymes of the liver.
Okay, they will be having significant drug interactions. If the sorry, inhibition of several enzymes which are responsible for the metabolism of other drugs, if you happen to co-administer the other drugs, which happens to be metabolized by the enzyme which is affected by cimetidine, what will happen? Inhibition of metabolism of that co-administered drug will lead to accumulation and maybe toxicity of the other drug. Indications: promotion of the healing of gastric and duodenal ulcers. Duodenal ulcer 70 to 90% 8 weeks. Gastric ulcer 50 to 75%. NSAID-induced ulcers, stress ulcers and gastritis, GERD, gastroesophageal reflux disease, and Zollinger-Ellison syndrome. In all these conditions, H2 receptor antagonists can be given. Adverse effects, generally they are safe, except for the cimetidine, which is not used nowadays. It is available but not used. Cimetidine causes gynecomastia in males, galactorrhea in females, as it has anti-androgenic effect and increases prolactin level. Besides, it has significant drug interactions because it inhibits CYP450 enzymes and increases concentration of warfarin, theophylline, phenytoin, ethanol, which can be, these drugs have low therapeutic index and they can become toxic because the metabolism is inhibited by cimetidine. So basically, cimetidine is of only academic interest in the sense that it was the first drug, it is a representative drug, it is a prototype drugs. All the new drugs launched in this class are compared with cimetidine, but itself it is not used. Now, the other class of drugs. Yes, any question?
Is the cimetidine androgen-like drug or what exactly?
Yes, it has anti-androgenic effect. In addition to that, because I did not want to show you the chemical structure, so it has additional activity in addition to H2 receptor antagonism. It is anti-androgenic, so it has got some separate side effects, which the newer generation H2 receptor antagonists like nizatidine, famotidine, ranitidine do not have. Only cimetidine does have those effects. So because of those drug interactions and serious side effects, this drug is not used now. Just of clinical, academic importance is given for the comparison purpose. So muscarinic receptor antagonists, you know the role of muscarinic receptors in the regulation of HCl secretion. Two drugs, pyrenzepine and telenzypine, any drug which ends with enzepine is also muscarinic receptor from this class. Reduce HCl secretion by reversible blockade of muscarinic receptors on the parietal cells. So muscarinic receptor has two roles. One direct on the parietal cells, insulin receptors, and indirectly through histamine release from the ECL, leading to increased release of HCl from the parietal cells through histamine. They produce anticholinergic side effects at doses that block HCl secretion. Because of poor efficacy, adverse effects, and a delay of gastric emptying because of the anti-muscarinic effect, anti-peristaltic activity, they are seldom used in treating acid peptic disease. The most important, most widely used class is the final common pathway inhibitors, proton pump inhibitors, which are the converging pathway, whatever the type of stimulant, gastrin, acetylcholine, or histamine, eventually it is the activation of proton pump which culminates into the decrease in pH of the stomach. So we will be discussing 4 drugs in this class: omeprazole, lansoprazole, esomeprazole, and pantoprazole. Any drug which ends with prazole is proton pump inhibitor. Okay, very easy for you. PPIs, proton pump inhibitors, their mechanism of action, they inhibit proton pump. Enteric coating allows release of prodrug intestine. I think a few times I have mentioned enteric coating. What does it mean?
It's coated by like specific materials that will be dissolved in the gut.
In the intestine, very good. So the pharmaceutical preparation of the drug, it is made in such a way, very cleverly, it is made in such a way, coating that it is resistant to be dissolved in the stomach. It withstands the acid and then passes into the alkaline medium, and over there it is dissolved. So it is made in the enteric coating, so it is dissolved in the stomach. At neutral pH of intestine, prodrug is chemically stable, lipid soluble, and devoid of inhibitory activity. So it does not act, it bypasses the stomach. It does not directly act on the other parietal face in the stomach. It must reach into the systemic circulation first through intestine, and then will reach to the required site of action through blood circulation, absorbed and carried by blood stream to the parietal cells in the stomach, diffuse into the secretory canaliculi. Acidic pH causes protonation and tripping of the drug near proton pump. It binds covalently with the sulfidal groups on the extracellular domain of the proton pump, thereby irreversibly inactivating it, resulting in decreased H secretion, because the pump is inhibited irreversibly. Acid secretion resumes only after synthesis of new molecules of proton pump, because once the proton pump has been covalently bound, inactivated, it is inactivated for life. Now the acid resumption has to take place after the de novo synthesis of new proteins, new pumps. Their inspecificity, the specificity of these drugs is conferred due to following factors. There's a selective distribution of proton pump in the parietal cells, nowhere else, only here. A requirement for acidic pH for drug activation, which is only here. Highly acidic medium is only in the stomach. And a trapping of the drug at the site of action. All these characteristics will confer a specificity of proton pump inhibitors only and only for the inhibition of proton pump in the stomach. Now let me ask you a question. The half-life of most PPI is approximately 1.5 hours only, almost all. And these drugs are generally given once daily. How this can be justified?
Because it's not reabsorbed to the blood easily, so that's why it's a stay for longer time there. But when it is in the blood, it takes 1.5 an hour to leave the body.
Okay, so you mean to say that since they inhibit the pump irreversibly, as I mentioned, the acid resumption may take place after the de novo synthesis of proton pump proteins. It may take time. It is a time-consuming synthesis of new proteins, new pumps may take several hours. So in that case, the drug is there. It persists only for a few hours. But since the target has been inhibited for life, so the effect persists. The drug, you cannot detect the drug in the circulation. It is gone. It is cleared from the circulation. But also, the target is gone forever. So PPIs are irreversible inhibitors of proton pump. The acid resumption depends upon the de novo synthesis of proton pump. Adverse effects are very few. Most common are nausea, abdominal pain, constipation, and flatulence. These are acceptable. Muscle and joint pain, mild. However, one thing, if you use this drug for prolonged periods of time, is hypergastrinemia, which may predispose to a rebound hypersecretion of gastric acid upon discontinuation of therapy and promote the growth of GI tumors, because gastrin is hypertrophic in nature and may actually from the GI gastrin secreting cells, because you are completely these are the most efficacious anti-secretory drugs, PPIs. In that case, if you are completely suppressing the acid secretion, reflexively there will be increased burden on the gastrin secreting cells. Actually, the gastrin levels in the circulation will increase reflexively. Gastrin secreting, there may be adenoma of the gastrin secreting cells as a side effect if you use this chronically. Did you get this concept?
Yeah, it's somehow like a negative feedback.
Yes, feedback, yes. Gastrin secretion will actually increase. Just like in the case of when you use ACE inhibitor, if you block the angiotensin 1, conversion of angiotensin 1 into angiotensin 2, actually the angiotensin level and the renin levels are increased after therapy with ACE, angiotensin converting enzyme inhibitors. The same mechanism is operating here. So we discussed first antacids neutralize the acid in the gastric lumen. We discussed 3 mechanisms by which we can decrease the HCl secretion from the parietal cells. The third is enhance the mucosal resistance of the gastric and intestinal wall towards HCl. Now, mucosal protective agents, 3 drugs we will discuss in this class. First of all, sucral fat, misoprostol, and colloidal bismuth. Sucral fat, didn't I mention at the start of this lecture that this lecture is interesting in the sense there are at least 2 classes of drugs, 2 drugs are there here which do not require a receptor to produce a pharmacological activity. We discussed antacids which act chemically, and we are discussing now sucral fat which acts physically. Salt of sucrose, complex to sulfated aluminum hydroxide. In acidic pH, sucral fat dissociates into components and polymerizes to viscous gels. The negatively charged sucrose octaphosphate binds with positively charged protein molecules found in the damaged mucosa coat over the ulcer. So whenever there is ulcer, the proteins, they positively charged proteins and the negatively charged sucrose, they bind together, and there's just sucrose makes a polymer over there on the surface, on the crater of the ulcer, and just produces a physical barrier between the HCl. It has nothing to do with the HCl secretion, but by being there as a polymer on the surface of the ulcer, it provides a physical barrier between the ulcer and the HCl. So it gives some time for the ulcer to heal spontaneously through natural mechanisms, and actually it removes the noxious stimuli from the HCl. So the physical barrier it creates between the ulcer and the HCl. So since it requires acidic medium to be dissociated into its components, so the concurrent use of antacids, H2 antagonists, PPI is avoided as it needs acid for activation. So the presence of that drug at a particular site will confer a pharmacological activity. Now let me ask you a question. Since H2 receptor antagonists or PPIs or antimuscarinic or antacids, they can be used in gastritis, in GERD, in other hyperacidity situation, even there is no ulcer. Will you use sucral fat for the same condition, for heartburn or for gastritis? This is very important conceptual question. Can anybody answer this? What is the difference between sucral fat and other drugs which we just discussed? Anti-secretory and antacids.
Sucral fat it's a physically acting drug. It's not chemically.
So in that case, my question is, a specific question is, if you encounter a patient with gastritis or GERD, not having any evidence of peptic ulcer, will you use in the previous cases, antacids and anti-CK drugs you can use in GERD without having any ulcer, you can use. But can you use sucralfate in those situations? The answer is no. Sucralfate is only and only used in the management of physical ulcer because this drug will coat the ulcer site. No ulcer, no effect of this drug. You can't use because it has nothing to do with neutralization of pH. It has nothing to do with the secretion of acid from the parietal cells. It just provides a physical barrier between the ulcer and the HCl, and the healing of the ulcer entirely depends upon your natural healing mechanisms. So no ulcer, no action of this drug. There has to be ulcer for this drug to be deposited on the surface of the ulcer. Is that clear?
So,
Yes,
doctor, I have a question.
Yes, please go ahead.
So let's suppose that there is ulcer in the esophagus or this place or another place than just the stomach. So it's supposed to work, huh?
Yes, not in the esophagus. Not in the esophagus.
Why?
Because it requires acidic medium.
Oh, okay, okay, thank you.
Okay? It requires acidic medium. Oh, there's a spelling mistake. Sucralfate. It has to be sucralfate. I will correct it. Adverse effects: constipation, black stool, and dry mouth. It is very safe in pregnancy since it is not absorbed systemically. Misoprostol, I'm sure we covered this drug in PUD block in the context of autocytes. Misoprostol, do you remember?
Inhibiting prostaglandin?
No, not inhibiting. It itself is a prostaglandin.
Oh,
Because when I take the lecture on antihistamines or drugs acting on autocytes, I always discuss this drug, misoprostol, in that lecture. I don't remember for your batch, I delivered this lecture or someone else. Anyway, misoprostol. Let's first revisit the role of prostaglandins in the stomach. Do you remember the first slide after learning objective? I mentioned a balance between the offending factors and the defending factors. HCl, H. pylori are the offending factors, aggressive factors. On the right side, I mentioned bicarbonate mucus and prostaglandins as the defensive factors. So this is a defensive factor, basically, prostaglandin. Prostaglandin, especially the prostaglandin E2 and to some extent prostacyclin, prostaglandin I, provides a protective action in the stomach. Specifically, they increase the release of mucosal bicarbonate and mucus from the epithelial cells. They have different target. Prostaglandins have different, they don't have a specific role, very important role, but this role increase the release of mucosal bicarbonate and mucus from the epithelial cells. Additionally, they inhibit to some extent parietal cell HCl secretion. So first action is through epithelial cells, second action is through parietal cells, and the third enhance mucosal blood flow through paracrine fashion. Autocytes, they actually enhance blood flow to the stomach. So three roles. Now based on this, just connect the dots. You know, religiously, the major side effect of NSAIDs, chronic use of NSAIDs is peptic ulcer. Can you figure out how NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or aspirin, how can they cause ulcers, peptic ulcers?
to increase the acidity and decrease the blood flow.
Just look at the three effects. Because NSAIDs, they decrease the biosynthesis of prostaglandins. By virtue of that, they will decrease the release of mucosal bicarbonate and mucus, all NSAIDs, by inhibiting the role of prostaglandins in the GIT. They will increase the parietal cell HCl secretion, NSAIDs, and they decrease the mucosal blood flow. All these factors will lead to causation of development of ulcer, and that is why we call it NSAID-induced ulcers. Misoprostol is a prostaglandin E analog. Modest acid inhibition, as I mentioned, the major role is mucus production. Stimulate mucus and bicarbonate secretion from the epithelial cells and approved for prevention of NSAID-induced ulcer. What are other uses of misoprostol? Just think. What are other situations where you can use more than NSAID-induced ulcer? This drug is being increasingly used, rather widely used, legally as well as illegally in some other situation. Think about that.
The heartburn, germ, maybe.
Not heartburn.
Action of labor. Prostaglandin E1 work on labor. Increased activity of the muscle in the uterus.
Very good. You got it. You nailed it. So in that case, when we say illegally, it is used, misoprostol is illegally used, what will be the clinical situations where misoprostol can potentially be illegally used? There's a legal indication, approved indication of this drug, but it is illegally also used in the same situations in many countries. It is used to induce abortion. Misoprostol is because prostaglandin also enhance uterine contraction, legal uses, clinical uses, approved uses to increase uterine contractions during labor to facilitate the delivery. But the same drug can also be illegally used when the abortion is illegal in many countries. It is legal as well as illegal. Adverse effects: diarrhea and cramps, because it increases the intestinal peristaltic activity. All smooth muscle contraction are enhanced, like in the uterine contractions. Peristaltic activity in the GI is increased, leading to diarrhea and cramps. Contraindicated during pregnancy, because it causes abortion, as well as it is teratogen. During pregnancy, it is contraindicated, but during labor, it is given to facilitate the delivery. The third mucosal protective agent is colloidal bismuth. Coats ulcer, similar to sucral fat, stimulates mucus and bicarbonate secretion from the epithelial cells. And also, it has been found to have some antimicrobial activity against H. pylori, may cause blackening of stools and tongue. Now we discussed neutralization of acid. We discussed anti-secretory drugs. We discussed mucosal protective agents, misoprostol, sucralfate, and bismuth. The last one is use of antibiotics if the H. pylori is the cause of the ulcer, if you have established.
Doctor?
Yes.
The last drug and the group before this, the colloidal, can we use it in the eradication of H. pylori also?
It is used as an adjunct. It is not highly effective antibiotic. It has some activity, but you can't rely only on colloidal bismuth to eradicate H. pylori. But I will cover this topic in the antibiotic, the last fourth strategy, how colloidal bismuth can be used as an adjuvant drug along with other antibiotics in the eradication of H. pylori. But you can't rely only on this drug. But this is not the major drug. It can be used as an adjuvant. Do you understand the meaning of adjuvant?
Yes, like
not the primary drug, but the secondary drug, helping the primary drug. Okay? So it has antimicrobial activity, but not to such an extent that you can rely only on this drug to eradicate H. pylori. But yes, definitely you can use along with other antibiotics to produce some additive effect. The fourth one is, do you know these gentlemen? Have you seen the photographs of these people? Okay. Let me name and then you may figure out. Barry Marshall and Robin Warren. Any bell ringing in your head? No? No cue? Okay, let me tell you the history. Very interesting. These were two Austrian microbiologists and pathologists who actually had created a significant impact on, they completely changed the healthcare and the management of peptic ulcer. Let me share with you my experience. When I was in third year, medical student like you, at your age, I developed duodenal ulcer. And the most modern drug at the time in 1986 or 87 was famotidine, which has only 1 or 2 years ago it was approved for use, and it was considered as a dramatic drug, very, very new drug. So I was given a course of famotidine. I used it for several weeks. The ulcer was gone, but it relapsed after discontinuing the drugs. After a few months, it came back again. So for several years, at the time when I was a student, at the time we studied that the pathophysiological mechanism of ulcer is only and only increased acid secretion. So just decrease the acid secretion or neutralize the acid, the ulcer will be gone. Ulcer was gone because of the healing mechanisms. Okay, but it came back again because there was something which was persisting, which was not being cured, and that was H. pylori. These scientists, Australian scientists, were the ones which actually they revolutionized the management of ulcer. They first time in, I think, late 90s, yes, early 90s. The first time they described that there is a role of H. pylori. This was against the norm. All the standard textbooks and throughout the world, physicians believed that it is acid, basically, acid secretion. They were the ones who showed, and their paper with evidence that we have cultured microorganisms, H. pylori, from the stomach, with evidence, all the significant papers of the world, they rejected their paper. So what they did, Barry Marshall, he actually cultured the H. pylori. He himself presented himself in front of the press and other doctors that look, at the time there was no endoscopy, there was, barium meal and those studies, imaging studies. He showed that, look, I do not have any ulcer. Clear? I don't have any ulcer. You are seeing. I'm dried up any ulcer. Then he himself ingested several petri dishes of cultured microorganisms, H. pylori, himself. And after a few weeks, he once again, in front of the press and other people, he underwent once again those imaging studies and showed. Initially, after 1 or 2 weeks or so, he developed symptoms of ulcer, dyspepsia, and 3 weeks, he showed the here's the ulcer. I'm having ulcer, duodenal ulcer. So he showed, and then after that, his study was published and that became revolutionary. And based on this finding, they were awarded Nobel Prize of Medicine, I think sometime in 2000. Yes, I think 2000 or 2001. I don't remember. You can check on the internet. So I was the one beneficiary from their treatment, from their revolutionary new idea. For about a decade or so, I was using H2 receptor antagonists or proton pump inhibitors off and on because the ulcer was coming and coming. So once this became a standard practice of using antimicrobial drugs, I was one of the beneficiaries. In 2000, the last time I used PPI and antimicrobial drugs for solitary duodenal ulcer, it has been, alhamdulillah, 2000 and now 20 years. No complaint at all. It has been gone forever. Because H. pylori were there. So in order to accommodate the fourth strategy, we use a combination of drugs to eradicate H. pylori. Triple therapy is a standard. This regimen most commonly recommended for first-line treatment of H. pylori. Keep in mind, I am always saying that when H. pylori is the established cause of peptic ulcer in some situations. If it is not, there's no need. Triple therapy with a PPI plus amoxicillin or metronidazole, one of them, and clarithromycin for 7 to 14 days, a combination of 3 drugs. And this is followed by a PPI for 4 to 6 weeks. This is a standard therapy for H. pylori associated peptic ulcer. And then we have non-bismuth based quadruple therapy. This approach involves the addition of metronidazole or denidazole to the standard triple regimen, which I discussed in the previous slide. It has the highest eradication rate, about 90%, even in areas with high clarithromycin and metronidazole resistance. I will show you in the last slide why sometimes quadruple therapy is required, not the triple therapy. And then someone asks, can we use bismuth in the eradication of H. pylori? Yes, this is the answer. This slide is the answer to that question. But not alone. Keep in mind, bismuth is not having significant antimicrobial activity, but it will aid definitely. So bismuth-based quadruple therapy, it consists of a PPI combined with bismuth and 2 antibiotics, for example, metronidazole and tetracycline given for 10 to 14 days. Now the question you may ask, why in some cases triple therapy and why in some cases quadruple therapy? It is used as initial therapy in areas in which the prevalence of resistance to clarithromycin is high through epidemiological studies. For example, in Saudi Arabia, I don't know if the studies have shown that the H. pylori prevalent in Saudi Arabia is resistant to clarithromycin. You won't go for the trial and error, start with triple and then replace with quadruple right away, because you know already that most of the strength over here or resistance, you will directly go with quadruple therapy. In patients with recent or repeated exposure to clarithromycin or metronidazole, if patients have already taken it and they have repeatedly exposed it is likely that the patient might have already developed. It is likely, not necessary. So you will start with quadruple. And when, of course, when triple therapy fails, you will go for the quadruple therapy. So now this is the slide which I have made for revision of the drugs used in peptic ulcer, 4 strategies: acid neutralizers, anti-secretory 3 subclasses, anti-muscarinic, H2 receptor antagonists, and PPIs, cytoprotectives like misoprostol, sucralfate, and bismuth, and antibiotics. These are 4 classes. Just a quick revision of what we discussed today. And if you have questions, then you can ask. We covered in, I think, 70 minutes, 10 minutes more. Okay. Overview of the drug targets. I have prepared this slide for you. It took me several hours, basically. Where should we start? Okay, from where we should start? Okay, first of all, appreciate 4 types of cells. ENS, enteric nervous system, vagus nerve, histamine secreting cells, histaminocytes, enterochromaffin-like cell, parietal cell, which secretes HCl, superficial epithelial cell, which secretes mucus and bicarbonate, which is the target mainly for prostaglandins, and the presence of H. pylori in the lumen, and this is the wall which separates lumen from all these cells. So based on this schematic representation, let's discuss the drugs. The first drugs, the drugs which neutralize acid will act on the lumen. They neutralize acid. The second class of drugs, H2 blockers, they will act on the H2 receptors and eventually will decrease the synthesis of acid into the lumen. The third class, antimuscarinics, they have multiple targets. First of all, they act on the histamine secreting cells and the ECL cells, and they will decrease the release of histamine by decreasing the influence of acetylcholine on these cells, because these are muscarinic receptor antagonists. And then the same antimuscarinics may act inhibit the direct influence of acetylcholine on the parietal cells by blocking this MC receptors on the parietal cells, eventually leading to decrease in the synthesis of HCl. And also, this we didn't discuss, but this also has, just like all the parasympathetic nervous system, they enhance the secretions, the body secretions. They also have influence, muscarinic receptors have influence on the epithelial cells. By virtue of activation of muscarinic receptors on the epithelial cells, they increase the production of mucus and bicarbonate. This action is also blocked by antimuscarinic. This is actually protective role, but which is blocked by antimuscarinic drugs. They decrease the bicarbonate and mucus production from the epithelial cells. And then we have PPIs, which block the final common pathway in the acid production. And then these were the anti-secretory drugs, antacids, anti-secretory drugs. And then we have the sucralfate, which binds directly with ulcer and coats it. It creates a physical barrier between the HCl and the ulcer. So it is a cytoprotective. Another cytoprotective, misoprostol. It's a prostaglandin analog. You see the role of prostaglandins acting through epithelial receptors. The mild influences, this is inhibitory pathway. It inhibits the production of acid from the parietal cells, and it also increases the production of mucus and bicarbonate from the epithelial cells. So prostaglandins have two roles, decreasing the production of acid and increasing production of mucus and bicarbonate from epithelial cells. So misoprostol is basically a prostaglandin analog. So both the decrease in acid production and increase in mucus production will be increased. What is the problem here? I just realized now. Can you identify the problem? Anybody?
Yes,
Just actually, on a lighter note, I should have used another symbol here, not the inhibitory symbol.
AGB1.
No, this is analog. All these are antagonists, antimuscarinic. So I chose this symbol of inhibitory. Okay? But here for misoprostol, the symbol should not be the inhibitory. It should be pillar symbol. Did you get my point?
Yes, it's supposed to be analog.
It is analog. It is not inhibitory. Now, while delivering this lecture, I realized that I chose the wrong expression here. So it is analog. It is not inhibitory in nature. It is stimulatory in nature. So it should be pillar here. So I'll change it. Anyway, so misoprostol is a cytoprotective. Sucralfate is cytoprotective, but the mechanism of action is different. Okay, then finally we have antibiotics and several antibiotics which they are killing the H. pylori and help in the management of ulcers. Okay, that's it. Any question?
No, thank you, doctor.
Good. So I'm always open to questions through email. Just ask. I'm just uploading after correcting. There are a few errors in the spelling and this last slide. I'll upload in the next 5 minutes. Okay. Okay. Good luck. Thank you very much. See you soon. Bye-bye.
Have a nice day.
Have a nice day.